We don't want to put any pressure on you. You're good for whatever you got to do. So we're going to mute here in the room, and then we should be good to go.
All right. Well, good morning, everyone. Sorry I can't be there in person. My name is Boughton. I'm an Lvads coordinator at Abbott Northwestern Hospital in Minneapolis. So today, just talk a little bit about heart failure and Lvads patients and what they kind of look like when they present to you. Let's see if I can get my computer to do what I need it to do here. There we go. I am going to talk specifically about heart pumps, but I don't have any payment by any of those companies. So I just work at the hospital. Speaking of Abbott Northwestern, part of Allina Health in Minneapolis. It's kind of our quaternary care center. So all of our advanced heart failure options come to us here at Abbott. Again, today we'll talk just what is a ventricular assist device or an LVAD. What are the what's different about care in those types of patients? What do we do in an emergency? And then I have just a very brief on ECMO, and please feel free to answer or ask any questions. If things come up where you've seen a patient and you have a question about something that happened on that scene or something like that, please let me know. I want to make sure that we are available to kind of cover what you need today. I always like to start my presentation by kind of taking one step backwards and looking at how do patients get to an LVAD. And really it's advanced heart failure. Heart failure happens when the heart really just can't pump enough blood and oxygen to support the other needs within the organ. You see when you look at the picture, you have a normal heart where we have this nice thick myocardium where the heart can squeeze and pump blood out to the body. But what happens in heart failure is the heart tends to balloon out, the myocardium gets real thin and narrow, and then it just can't squeeze out blood enough to the rest of the body. You can see when it starts to balloon out, everything kind of stretches. That means the valves stop working appropriately and the heart muscle itself stops working appropriately. And it's really challenging to treat patients once their heart has really started to dilate. When we look at heart failure as a whole, almost 6.5 million people in the United States have heart failure. And to me, the most staggering statistics is if people are hospitalized with heart failure, their average survival is 2.5 years. It's really a pretty horrible prognosis. It's worse than most cancers. And I just don't think enough people are aware that it's really that severe once we get to hospitalization with these patients. When we start looking a little bit further at advanced heart failure, what does that look like? Advanced heart failure is really one step further when we are no longer able to compensate. And we have, in the heart failure community, have this acronym that we use. It's called I Need Help. And really the three big things I look at for patients that I know are going to be in crisis for me is end organ dysfunction. So when their creatinine or their kidneys stop working appropriately because they're not getting enough blood, when they've been hospitalized at least once. And to me, the really big factor is we no longer tolerate medicine and we have to down titrate their goal-directed medical therapy or all their heart failure medicines that they're on. As soon as we start having to come down on those, we're in big trouble with these patients. So what can we do for them? When we have advanced heart failure, we have a couple of different approaches that we can take to these. When we look at patients, we really explore all of these options with the patient and decide which one is the best approach for them. So we have kind of a palliative approach where we're going to continue with medications and supportive cares, but we're really not going to escalate to some of those advanced option things that we have. Some people choose that option. Some people choose where we use IV medications. Sometimes when they kind of come back into the hospital frequently, we use IV diuretics. Lasix and Bumex are kind of the key names that we use for those. And then we also use inotropes. They help us increase the squeeze of the heart. And those are dobutamine and milrinone are the kinds that we tend to use. Some people are able to go home on an infusion of dobutamine or milrinone. But interestingly, the literature shows us that at 6 months, somebody on an inotrope only has about a 50% chance of survival. And at a whole year, we only have about 20% chance of survival if that's the route that we choose for a patient. So we do talk about that as they're kind of choosing how they're going to treat their heart failure. We have heart transplantation. That's kind of the gold standard, but we all know that the problem with heart transplant is there's only so many donor hearts available to us in the United States. So heart transplant, where we take out the failing heart and we put in a new healthy one. There's been some new kind of exciting advances in this field in the last year or so. We have the standard approach that happens following brain death, where we can do transplantation. But we now have what's called the organ care system, sometimes otherwise known as heart in a box, where we can do donation after cardiac death. We can also do donation from far distance. The biggest part with transplant is once the heart comes out of the donor, we have about 4 hours of time before we need to put it into the new patient and have it start perfusing, or we're going to lose tissue on that. And so this organ care system allows us to actually move and pull in organs from farther out. Here in the Midwest, it's challenging because if we look at our donor circle, we look at Minnesota, Wisconsin, North and South Dakota, maybe Eastern Montana. But when we look at that range, we're really looking at, there's not a lot of population in this area. And then there's also, then we have Canada to the north, where it's very challenging to bring in organs from through customs. It's been done a time or two, but it is challenging. So we just don't have this great big base, and using the organ care system allows us to travel, say, to Texas or to California and bring a heart back for our patients here at our facility. So that's one option, but we don't have as many of those as we would like. And then the other option that we look at is VAD, or ventricular assist device. And that's mechanical circulatory support that we can basically pull off a shelf, implant into somebody, and help them get their blood flow kind of working. In this option, the native heart stays in place, and we're using the pump as an assistive device. So when we meet patients, we really talk about all of these options, and we decide what is really the best method. Today's focus is going to be ventricular assist device, or LVAD, VAD or LVAD, kind of depending on how you call it. Currently, there are patients with 3 different systems in place. The ones in the white there, Heartware, HVAD by Medtronic, and the HeartMate 2 by Abbott. We have patients with these devices still in place, but we are no longer implanting them, because we have found that the newest technology we have in HeartMate 3 is significantly better. It has reduced our complications very significantly, and it's increased our survival with our patients. And so we are only implanting that pump called HeartMate 3. It's made by Abbott Labs, not to be confused with Abbott Hospital, where I work. We are not affiliated with each other, but it is the kind of gold standard heart pump on the market right now that we use. The interesting thing about all of these pumps is that they provide continuous blood flow. So in a normal heart, we have the heart beats and relaxes, and so we have this kind of squeezing action happening. The heart still does that around my pump, but the pump acts as a continuous blood flow. So it's going to pull blood out of that left ventricle, circle it through the pump, and then push it out through that outflow graft and into the aorta, where it circulates throughout the rest of the body. This continuous blood flow poses a little bit of a challenge for us providers, because it does change how we assess a patient in this situation. I'm going to, hopefully my video works here. Let's give it a whirl. So this is just going to show a little bit about what the pump does in relation with the heart. So as we look at it, the heart's still going to squeeze. You can see that the pump is implanted at the base of the, we call it the apex of the left ventricle, where the blood's going to come down. It's going to be pulled through that pump, circulate through the system, and then pushed out through that outflow, that white outflow graft, to the ascending aorta, where it then circulates out throughout the rest of the body. As it zooms in here, you'll be able to see the blood is going to come down through that center. And then the pump has magnetic levitation, where that impeller is spinning constantly and pushing blood throughout, and it's going to push it back up through that outflow graft. So we implant the pump inside the patient's chest, and then we'll see this white tube kind of coming down and out the abdomen. We call that the drive line. That's going to be, and they call it 2 different things, but in general, we call it the drive line. That comes out the patient's abdomen. It's going to attach to that computer or controller that you see at the base of the patient there. And that's going to be the brains of the operation. That's going to run our pump. If that is ever off, then we are, if it's disconnected, we are not pumping with the pump. This continuous blood flow, this is where it poses a problem for our patients. So the way that it works, your heart works by contracting and relaxing in a normal state. By doing that, the valves open and close and push blood throughout the body. But because the pump is continuously flowing, there's actually not a pressure gradient change between the left ventricle and the aorta. So the valve doesn't always open. When the valve doesn't always open, it means your patient may not have a pulse. That's the biggest thing when you're assessing these patients, is they may not have a pulse present, and that is okay. Because they don't have this pulsatile flow, it means that blood pressures are going to be difficult to obtain. So we might have to look at other signs of perfusion. We might have to look at, are they mentating okay? Are they awake and talking to me? Even if I can't get their blood pressure, they have adequate perfusion to their brain. So we're getting enough blood pressure to be somewhat stable. We have to look at coloration and cap refill if we can't get a blood pressure for our patient. If we can get a blood pressure for our patient, and we can use the non-invasive, most people don't have Dopplers and manual blood pressure cuffs. We can try the non-invasive. If we get it, the one thing that we need to be very aware of is that the pump's continuous flow augments our systolic pressure low and our diastolic pressure high. So our pulse pressure difference may be very narrow. Not uncommon to find an Lvad patient that has a blood pressure of 80/70. Totally perfect for our patients, even though that's low for the standard patient. What we're looking for is a mean arterial pressure somewhere between about 60 and 85. That's going to be an adequate pressure for any patient with a pump. If we are looking at oxygen saturations, again, that's going to be based off of pulsation. And so that may be difficult to obtain. Again, we're going to have to look, what is our cap refill? What's the coloration of our patients? Are they blue and do they look hypoxic? Or are they nice and pink and look like, hey, we might be doing okay on that. So that can be a challenging one. The other thing to be aware of is the HeartMate 3 pump does a automatic speed change 30 times a minute. And what happens with our O2 sat is it likes to read us a pulse rate of 30. And that's really it picking up the pulse rate of the pump, not the pulse rate of the patient. So just be aware of that. It's going to be a little bit of a challenge on our on your assessment that way. If you put on an EKG, you're going to notice that the pump doesn't affect the EKG, but you're going to get this really crappy, junky baseline artifact like I have there. The baseline artifact is coming because the pump is magnetically levitated. So we're getting all of this junky artifact, but you can still see based on looking at it that we have a nice regular rhythm that's fast enough. It's not 30 that we're going to go okay. If you're trying to get leads, if you're using just 3 or 5 leads, the farther away from the left chest you can place your patches, the more likely you'll get less artifact. So I like to put my kind of my upper leads on the back shoulders. Limb leads, if you're using them, put them way down on the legs. That seems to help. And even if you're doing a 5 lead, that chest lead, if you put it on the right side of the heart or the right side of the chest, even just that pulls it away enough that you might get a little bit better of a baseline to look for something. If anybody's using an arterial waveform, the waveform that we see here is the aortic valve is not opening at all. Those little blips are the pulsations that we're seeing that the heart pump is doing. So again, you'll see my blood pressure for this patient is 79/53. Totally perfect for an Lvad patient. It's a mean of 69 or 70. Very adequate for this patient population. It's just unusual as we kind of look at the normal patient compared to what our patients look like. Lvads are very sensitive to pressure. So when we are taking care of these patients with these centrifugal flow pumps, we know that anybody in a high pressure state, they aren't going to tolerate, the pump isn't going to tolerate it. It's kind of like using a garden hose and you put your thumb over the end of it and it kind of sprays everywhere. That's kind of what the heart pump does. It can't tolerate this high pressure. So we have to bring our pressure down. One of the alarms that we get, and I'll have it on another slide here, but one of the alarms we get with the pump is low flow. And it comes across as a critical alarm because we want it to know if our patients are in a low flow state. I would say at least 50% of the time when we get this alarm, it's because the patient has high blood pressure and the pump just can't do its job. If we bring the blood pressure down, the pump starts working appropriately. Same with any patient, low blood pressure is not good. They're going to be lightheaded and dizzy. We also know that VAD patients or VAD pumps are very sensitive to volume. They have to have enough volume to work. So if we have patients that are dehydrated or that are bleeding, they aren't going to tolerate that situation very well. The pump needs enough blood or volume to work. So when in doubt, give more volume. If we have too much volume in the acute state, honestly, it's not the end of the world. We just diurese it off down the line. But if we have patients that are lightheaded, dizzy, or with low blood pressure, my first is always give them a half a liter to a liter of fluid and see if that resolves the issue, because they might just be hypovolemic and we need to figure that out, why they're hypovolemic down the line. This is just kind of in the back of your head. Patients are on blood thinners because of the way the pump works. The body wants to build a clot in and around the pump, mostly inside that pump. So we do use warfarin and an antiplatelet agent, typically aspirin, sometimes another. So patients are on blood thinners. So as you're doing your assessment, keep that in the back of your mind. Is there something going on because of their blood thinners? Is their blood too thin? As we do, I'm going to shift a little into kind of emergency care of this patient. How do we assess and what do we look at when we see these patients as we kind of come in? Complications that go along with this pump, and bleeding is the #1 cause. Upwards of 25% of patients will have at least one episode of bleeding during the time that they have their pump. The most common areas that we see bleeding happening are GI or gastrointestinal, and we see head bleeding happening. So we're going to treat bleeding pretty much the way we treat it with anybody else. We would like to decrease their anticoagulation and stop the bleeding in whichever ways that we can. The only thing that we ask is that we are consulted before we completely reverse anticoagulation, just because of the clotting risk that goes along with the pump. So thromboembolic or clotting options are the complications that we see. The most common two places that we see it, clots form inside the pump, and then they can be thrown because of the mechanism of action of the pump out to the rest of the body. And the most common place they land if they get thrown is in the head, and we see a stroke. We typically don't do thrombolytics for our patients with clots because we know that the base of the clot typically is within the pump itself. The only way to treat a clot formed inside the pump is to surgically remove the pump and put a new one in. So if we give a patient thrombolytics and then we have to change out their pump, it's kind of created a disaster for us on the back end that in the next 24 hours, we're just going to have massive bleeding for our patients. So typically we like to avoid thrombolytics, get them to us and kind of treat things the way that we do surgically with our patient. Infection. We see infection happen. The most common place we see it is at the driveline exit site. So right where that driveline or that tube comes out of their abdomen and exits their body, it's kind of exposed to the outside world. We treat our patient, or we teach our patients how to do a sterile dressing over that driveline. So very similar to how we do it with a PICC line, with using kind of chlorhexidine or betadine and keeping that sterile to avoid infection. But if it gets tugged, pulled, dropped, somebody doesn't follow the directions, infection can happen there. We can also see infections happen elsewhere. We see a lot of dental abscesses where then that patients become bacteremic. Dental bugs, unfortunately, are super sticky and they like to stick to mechanical things inside the body. And so they tend to stick to our heart pump. So that's another potential source of infection for our patients. We're going to treat them like we would anybody else. Right-sided heart failure. When we start talking about heart pumps, we talk a lot about left-sided heart failure is supported by the pump, but the right side is not mechanically supported. And we can still see the right heart slowly fail over time with these patients. The heart failure progresses around that heart pump. And so we can see volume overload happen. We can see the need for adjusting the heart pump. Those are all kinds of things that we would bring the patient in and admit them for treatment. And then the big one that people are most scared of, though it doesn't happen very often, is a pump malfunction. The pump malfunction would present with an alarming pump. I have a picture of kind of what it might look like in the next few slides. But a pump malfunction, if the pump is alarming, the biggest thing is to call us and we will help walk through what that looks like. So in a pump malfunction, the patient has extra equipment that they have. We may ask and direct you to do some things with the equipment in that state to try to get that pump functioning again. Our number there is on the bottom. I have it in a couple of other slides as well. Patients also carry that number with them. When we look at our key points to a physical exam of these LVAD patients, again, remember no pulse, so that's okay. I'm not super nervous about that. We may or may not get a blood pressure. Again, look for other signs of perfusion. When you're listening to heart tones, they're going to be obscured by the pump. So the pump has a very mechanical hum sound. Depending on which type of pump it is, it may be a continuous sound. It may be one that has a variation that happens every 2 seconds. That's what my HeartMate 3 pump sounds like, a mechanical hum, but it has a kind of a hitch in it every 2 seconds, and that's normal for that pump. If we're going to look at that external driveline where it attaches to our body, we just want to make sure that we try to keep the site as sterile as we can. And so wearing a mask and then peeking at it and then placing a dressing right back over it so that we're keeping it as sterile as we can. If we're trying to do other exams, leaving the dressing intact, but like, palpating and things around it. Things that are super important to me when I talk to patients or assess patients are, do we have fever and chills? What about neuro changes, headaches, vision problems, things like that? Things that indicate bleeding, dark tarry stools, frank blood that we have noticed, cardiovascular symptoms where they're complaining of shortness of breath, lightheadedness, dizziness, syncopal episodes. Those are all super important things with these patients. And then again, if the device is alarming, patients and their families are usually able to tell you, or if you approach them and their pump is screaming at you, you'll right away know that the device is alarming. So there are 2 types of alarms that the device itself can make. Yellow, they're advisory alarms. The big thing about them is they beep. They're never life-threatening. They are a power issue. They are a issue that tells us, hey, we should probably address this in the near future, but it's never something that's going to be critical. So beeping, yeah, we want to fix it, but it's not going to harm the patient in the short term. The hazard or the red alarms are the ones that are going to scream at us, and you can't miss them. They're about as loud as a smoke detector, and they're just this loud, continuous screaming noise. Those we want to look at and address right away because they could be life-threatening. They may tell us that the pump has low flow, like the screen has, but they may also tell us that the pump is off and not working. So what we want to do is assess that controller if it's alarming and tell me, is something, what is it saying on it? And then we can talk through how are we going to fix it. If the pump is off, I'm going to tell you to do something different than if you tell me that it's just low flow or if it's a low battery issue. So we want to be involved and help you assess and figure that out if the pump is alarming. Be aware when you're exposing the patient that this driveline, the center picture is what it looks like without a dressing coming out of them. You may see a gauze dressing, you may see a clear dressing like over a PICC line, but just be aware that it's there. Please don't cut through it. It's going to shut the pump off and then we're going to have a bigger problem on our hands. But again, even if you're just helping somebody to get undressed, be aware that that may be snaked through their clothing. A lot of people like to wear a undershirt that's meant for conceal and carry. Those pockets on the sides beautifully fit the batteries for the heart pump. So just be aware that that may be something that they have wearing attached to their body. It might not be laying separate to them. As we shift into some of the emergency things, what may happen? Rhythm disturbances are the biggest thing that we see with patients that are different in a critical situation. Because the continuous flow of the pump, patients may tolerate these rhythm disturbances way more than other patients. So we want to make sure we're assessing the stability of our patient. I know we follow ACLS and we say, you know, if the blood pressure is low or whatever. I feel like if the patient is awake and talking to me, I've got a few minutes to assess this rhythm and see what's going on. It is very common for patients with these, and these actually, the VT strip is a patient that they were actually in VT for about 3 days, tolerating fine. The VFib strip that's on here, that patient was in VFib for about an hour and a half talking to the emergency room physician, and they just couldn't believe that that was what was happening. So these patients really can tolerate these arrhythmias for a long period of time. And we want to get them out of it because ultimately we want to preserve the right side of function of the heart. But they may not have an arrest right away with these uglier type rhythms. So we want to make sure that we're looking and assessing, put somebody to sleep if we can before we shock somebody out of these rhythms if they're awake and talking to us. I've had somebody attempt to be shocked while awake. Doesn't go well for anybody. So what we like to do is, if either one of these patients are awake and talking to you, I would say, let's transport them to the local center. Obviously, if they decompensate en route, we'll do what we need to do. But we do tolerate these rhythms as long as they're kind of awake and have some blood pressure behind them. Look to treat what is the underlying cause of this emergency. Chest compressions may not fix what's going on with our patient if we're in an arrest situation. We might be having an arrest situation because the pump is off. We might have an arrest situation because we're super hypovolemic and the pump just doesn't have enough blood or volume to push through the body. So consider giving fluid. And then in the back of your head, I like to keep, what are those complications that go with it? Bleeding is number 1, but then look at clotting and stroke. If we have an unconscious patient, stroke is my number 1 thing that I think about. Even though I may not be able to palpate their pulse, they may not be in an arrest situation. It may be more of a stroke situation. So just kind of thinking about that in your back of your mind, that these patients do present a little bit differently. Each patient has an emergency or a travel bag that we ask them to carry with them. So if you're at the scene with a patient and you're transporting them, ask the patient and or their family, where is that emergency equipment? We want that to come with us. Especially given your location, you're a few hours away from us. We want to make sure that we have enough battery power to get the patient back to us if we need to. In these emergency bags, they do have their phone number to us, that emergency number, but they also have an extra controller that's set exactly what their pump is set at. They have an extra set of batteries and then those battery clips. If we can't, if we don't have those, then we're not always safe to get the patient transported back. The bonus is these pumps are really good these days, and the batteries last approximately 16 hours as a set. So we do have a little bit of time as long as they're fully charged. But if we have the batteries the patient is wearing plus their emergency bag, we've got 24 hours of wiggle room of battery power for these patients. So we like to keep them kind of as safe as we can with that. When we're going to transport, we want to go to the closest facility that we can to stabilize the patient. And then we would likely recommend that they be transported on back to their implanting facility. I work for Allina in Abbott Northwestern, but there are a few other facilities in Minnesota that do LVAD patients. So the University of Minnesota and Rochester Mayo also implant LVADs. Any of us can take any of them, but ideally we like to go back to the implanting center because really we just know the patients well enough. We know what their history brings. If they happen to be full, we do share and take on each other's patients if we need to. Bring that emergency bag with them. Just being careful with that equipment. Don't allow it to fall or get kinked, that it would allow us to not have good function of it. And then any of these devices are fine for either ground or air transport. There's no issues with that in any of the pumps. Are there any questions so far? Okay, I'm going to sneak into a couple of patient scenarios because these are the three, I'm going to give you three scenarios, and these are the main three things that we get called for. Actually, the first two are the main ones, and then the third one is not a main one, but it's there. So patient scenario number one, EMS gets activated, patient is unconscious, but the VAD is not alarming. So you can contact us. Our number, patients usually wear a medical alert. It's in their emergency bag. We do also place it on the back side of their controller. So that's another place to look for it. Obviously, we're doing these things at the same time, so we can use our fire or our police helpers to contact us as you guys are taking care of the patient. But we're going to look at perfusion. So how are we going to assess perfusion in this patient? We don't have a pulse. Looks like we have decreased LOC. We have minimal effort with breathing, but my patient is still warm pink and has some good cap refill. I'm not able to get a blood pressure. How are we going to go about treating this patient? So if we think we don't have a pulse, well, I don't really care about that. I'm going to keep going on to the next one. Breathing. If they have minimal effort with breathing, we're going to assist them as we can. So whether that be bag breathing, intubating, monitoring with end-tidal CO2 if you have it, how can we assess and assist with their breathing? Blood pressure. We can't get one. It's okay. We may not. But because they had this warm pink skin, I'm going to assume that we have an okay blood pressure going on with us. So we're going to stabilize as best we can on the scene, and then we're going to transport into our nearest facility. Don't forget your LVAD equipment when you come in. When we get into our facility, we were able to do a little bit more testing. This patient looks like they've had a hemorrhagic stroke. So we're going to bring them in and treat them the best that we can. So really, no, they didn't have a pulse. No, they didn't have a blood pressure that you could obtain, but circulatory wise, they were okay in the situation. Their pump wasn't alarming, and they still had this warm kind of pink skin. We were able to get there before we got to a full arrest state in this stroke situation for this patient. In the next scenario, EMS is activated by the patient. When you get there, he tells you he's super weak and dizzy. All he can do is lay down. Every time he stands up, he's feeling terrible. And you hear this loud screaming alarm in the background. He tells you his pump is alarming, low flow. So you can contact us if you need to. And then we're going to look at perfusion in this patient. So we don't have any pulse. We have adequate LOC because he's talking to us. Breathing is okay. Skin color, not the best. Slow cap refill, kind of cool, but he's still talking to us. So we still have an adequate blood pressure, even though we're not able to obtain a reading. So in this case, he doesn't have a pulse. I don't really care. He's breathing, awesome, but that VAD is alarming. So what are we going to do about that? We're going to call the VAD coordinator. So we can ask the patient to either call us, and sometimes they may already be on the phone. They might hand you the phone and say, hey, here's my LVAD coordinator, please talk to them. That's not uncommon for a patient or family member to do. If you have the ability, we would ask for them to get some fluid. If they don't have that ability, we might need them to have, if they're able to, drink some fluid in the short term to try to get us some fluid on board. That should help with the dizziness a little bit. Cool extremities. I'm going to assume that they have low blood pressure, but it's not so low that they're not stable enough with their mentation. We're going to try to get them to the closest facility. And when we get there and we do a little bit more assessment, we're finding, hey, hemoglobin, not good. Patient then tells us on our assessment, like, hey, I've been having these black tarry stools for a few days. The last time they checked my INR, it was, 5. And so that may be something. We get a lot of these GI bleed, low hemoglobin type calls. Sometimes the patients will tell you they've had black tarry stools. Sometimes they'll say, no, they've been fine. Nothing has changed. And then it's not until we scope them, they're like, oh yeah, it's been different for 2 weeks. So, patients, as they kind of walk through their situation there, we hear different stories with different providers as we go. And then the third scenario I'll present you with is that EMS is activated, the patient is found unconscious, and the VAD is alarming low flow. This one is kind of everybody's worst nightmare. I bring it up because of that, but realistically, I have been an LVAD coordinator for 12 years, and in those 12 years, I've only dealt with this 3 times. So it is pretty rare when it happens that we have an unconscious LVAD alarming low flow. As we, you can call us with the VAD alarming, have somebody else, but as you're assessing your patient, we don't have a pulse, we have decreased LOC, we really don't have any breathing, we have blue color, bluish cool skin, we're not able to get a blood pressure. How are we going to go ahead and treat this patient? Realistically, they don't have any signs of perfusion, so we need to resuscitate them the same way that you would anybody else. With the LVAD, the only difference is we want to look at the pump and see if the pump is on or off. If the pump is off, then we may need to look at that equipment and do something more to it, because the pump being off may be the reason that we're in this arrest state. If the pump is on, we've looked at it, then we're going to treat the patient that we weighed anybody else. It is okay to do chest compressions. It is okay to use a manual compression device, whether it be Lucas or any of the other ones on the market. And it is totally fine to use any sort of AED or defibrillator. A lot of times our patients have internal devices, but there are a handful of them that don't. And so using something external is totally fine. So you don't need to do anything with the equipment or the pump. Get them to the closest facility. If they happen to survive, we'll take them back and be able to kind of take on treatment from there. Again, like I said, it doesn't happen very often that this happens. In a couple of the cases, it has been, I've only ever had one case where the pump was completely off, where we needed to do something with the equipment. The other times it has been the patient has had an arrest for a different reason. Again, our emergency number, we are available 24/7. When you call that number, you're going to get one of the nurses that is specialized with heart pump. And then a lot of times patients or family have already called us, and we've either told them to activate EMS or there's 2 phones going on where they're on the phone with EMS on one hand and we're on the phone with the other. So it's not uncommon for somebody to kind of throw a phone at you or somebody when you walk in the door. You can always hand that off to your friends with in the police department or the fire department if you're wanting to take care of the patient, but do have questions for us. When we admit patients to Abbott Northwestern or the Allina, we have an Allina Access Center that allows you, it's a phone tree, but really the first one is you have a critical patient, hit number 1, and it'll prompt you through to somebody from that regard. Nobody can get through a presentation without statistics. But my favorite thing to share about the statistics with LVADs is that we have just recently gotten some really good 5-year data that shows that LVAD patients really do help patients survive in the long term. So if we think back to the very beginning, I told you that patients that have 1 hospitalization for heart failure only survive about 2.5 years after that time. That's a not very long time for patients to survive. And we know when patients are needing IV medications to help increase the squeeze of their heart, their chance of survival at that 1-year mark was only 20%, is kind of what the literature tells us. So when we look at what do we get with heart pump therapy, so you can see the very top line there is 2-year survival and my graph, 2-year survival, heart transplant, 82%. HeartMate 3 LVAD, 79% survival at 2 years. That's a huge mark, and we're almost matching that of transplant. So now we're looking at, as we decide this treatment path of patients, one thing everybody doesn't know about transplant is the average transplanted heart, or graft we call it, only lasts about 11 to 13 years. So if we take a patient who is 30 years old, that's not increasing their life expectancy very long. We'd like to get them into their 50s and their 60s. So what our strategy has been lately is to put an LVAD in these patients. Maybe we can get 5, 10 years of time and then look to transplant. It means we're pushing their life expectancy out significantly down the line. The bottom line on that graph, 8% survival after 2 years is optimal medical management. So those are those super sick patients needing IV medications, 8% survival at 2 years. Pretty terrible when we look at the comparison. But over in the corner are 5-year data. So the US trial that we was just published here in the last few months says 58% of patients with LVAD are still alive after 5 years. And if we look at Europe and the Middle East, they have a little, their inclusion criteria is a little bit softer, but they're getting 63% survival with their patients. As we shift out of trial mode, it's been 5 years since this data has just been collecting. The preliminary data we're starting to see in our real world situation, which takes into account even sicker patients, is that the US is matching that of Europe. So we're somewhere between that 61 to 63% survival at 5 years. So we're really able to give people a lot longer time. So longer is important, but so is how do you feel? So when we look at what is the patient's experience and how do they feel? So significant improvement. It takes about 3 months to get over the hump of surgery and have your body adjust to this new therapy, but lasting at least 2 years, maybe longer, we're seeing a huge significant improvement in their ability to walk, their ability to kind of do their daily lives. And then my biggest, or my favorite one is that bottom, increase in satisfaction of life with heart failure. So we're going from 14% of people say that they are okay with how their life is to 70%. We're getting a huge increase in quality of life for our patients. And that's really the mark that we're looking for. How can we make people feel better for longer? I'm going to briefly touch on ECMO. So ECMO is a therapy that is extracorporeal membrane oxygenation. It's a temporary support used to manage immediate life-threatening cardiac or pulmonary failure. It can be instituted super quickly, and we can support patients for a couple of days to a couple of weeks until we can either get them to recover or we have the chance to do something different. Maybe we can bridge them to a transplant. Maybe we can bridge them off to an LVAD for these patients. ECMO is essentially a modified version of cardiopulmonary bypass that we use in the operating room for patients, but we've made it into a support that we can use for a little bit longer term to give patients this bridge until we can either recover them or get them onto the next step. There's 2 methods. So there's VA ECMO or veno-arterial. This can support both cardiac and respiratory needs. It allows us to provide oxygen and removal of carbon dioxide while circulating this oxygenated blood throughout the body. So it's drained from the venous system. So the blue system is draining out to my pump where it is oxygenated and the carbon dioxide is removed. And then it is pumped back through the arterial system and back into the patient's body. This is a support that we use for cardiac failure. If you've heard about eCPR, or where we're able to put patients on ECMO in the process of doing CPR, this is the method of ECMO that we use for that. Then we have indications, cardiogenic shock, post-arrest. We can use it septic shock where patients just aren't doing well at all, pulmonary embolism, heart failure type things. So VA ECMO. Then we have VV ECMO or venous ECMO, which is providing respiratory support. So it's not circulating throughout the body as far as the pump goes, but we pull from the venous system, we oxygenate, and then we put back in. And so what this allows us to do is lung rest. This one has made a huge surge with our COVID patient population. We use this a lot to help support people during this COVID time. So again, drainage from the venous side, going through the pump and the oxygenator, and then we're going back into the pulmonary system where we're then pumping out throughout the rest of the body. The heart is actually doing the circulation, and the machine itself is just doing the oxygenation in VV ECMO. So again, ARDS, aspiration, status asthmaticus, influenza. Every year we have a number of patients that are influenza patients that get put on ECMO. And then again, COVID was a huge one in the last few years. When we look at complications, so bleeding, huge. We're using big bore cannulas, typically into the femoral areas because it's the easiest, quickest access that we can get. We have to be aware of blood clotting through the system. So we can have blood clotting form within our pump or our oxygenator. Because of that, we give people blood thinners. We have to be aware that we can then create blood clotting disorders where now we're not able to clot with the system. So it's a kind of a finely balanced. We do see a lot of hemolysis, breakdown of red blood cells, because we're pushing this, the blood comes outside of the body and it's being pushed through the system. So we do see this lysis of red blood cells. Again, we can see infection as we're doing a lot of instrumentation. Limb ischemia is there, though I would say in the last 5 years doing adult ECMO, we have really been able to decrease our cannula sizes and really protect limbs. We're not seeing as much limb ischemia as we used to with these patients as we are kind of getting, perfecting the cannula sizes that people need. So this is just our 2022 ECMO data from Abbott alone. There is a national and an international registry, but I think it's nice to see it. So ECMO, VV ECMO, the respiratory type, people tend to be on it longer. Lungs take a lot longer to heal. So our average time that we run people on VV ECMO, about 17 days. Longest being 38, that was a COVID patient. But we do have a pretty decent 80% survival. VA ECMO or cardiac ECMO tends to be a shorter run because we typically bridge to something else. We don't like to keep people on VA ECMO for much longer than a week if possible, because we can bridge them to something longer term like an LVAD. Percentage survival of VA ECMO is 50%. A lot of times these are patients that are post-arrest that are really struggling and have overall bad heart failure. And then eCPR, these are ECMO patients that have been cannulated during a cardiac arrest. Average length of time, again, is pretty short because we like to bridge them to something else if they need it. But again, a 40-some% chance of survival is pretty darn good when you think about these patients were having a cardiac arrest at the time that they were cannulated for their ECMO. The Minneapolis Heart Institute does have an app for CV emergencies. It doesn't just include ECMO and LVAD. It does have acute stroke type issues. It has acute limb ischemia. It has cardiac arrest. It has acute STEMI, all of those types of things that's available for the CV emergencies program that we have. And then last but not least, it's really nice to see what do patients look like with these devices. So I've got some patients that are have been through the ringer, to say the least, but here's what they look like. So this is my friend Andrew. Andrew works with us at the hospital, and you would never ever know in a million years looking at him wearing his scrubs that he actually has an LVAD. He's had his VAD for almost 5 years now. He works in device therapy, so he actually works for a pacemaker company at the hospital. He chooses to wear his equipment kind of around his waist. He likes to wear his stuff in a fanny pack on the back because it's out of his way as he's taking care of patients. He did get married, so in his suit there you can't tell, but he really does have an LVAD in, and he and his wife just welcomed us a baby girl about 9 months ago as they're kind of proceeding with life. Andrew is a young guy. He's 29 years old. He is not currently interested in transplant. LVAD is giving him what he needs. He wants to ride this out and see how far he can get, knowing that those donor hearts really kind of offer us on average that 11 to 13 years. He wants to be around for a lot longer than that. So he's willing to ride out LVAD for as long as he can. And he may eventually become a transplant candidate down the line. So here's a patient that went from ECMO to LVAD. This gentleman actually came into us from Minot. He had a cardiac arrest while hunting with his children. He was put on ECMO and flown to us. And then he was implanted with an LVAD. So Marty had his LVAD for almost 10 years before he passed away. He had many complications along the way. As we look at what some of those complications can be, he had underlying Crohn's disease, which predisposed him to things like GI bleeding. So he had many, many, many episodes of GI bleeding with his heart pump. The problem was we couldn't take him off of blood thinners because the type of pump he had was really at risk for developing a blood clot if we stopped him. So he had dealt with GI bleeding for a time with that. And then he also, throughout his time on LVAD, he actually developed lung cancer where he was treated with radiation therapy. He did get about another 3 years after that before eventually passing away. But in total, he was just a few months shy of 10 years on LVAD support. He was 68 years old when he had the VAD put in. And then here's one of my favorites, people outliving life. This is the whole goal to me of LVAD therapy. This gentleman, while roller skating with his LVAD on anticoagulation is maybe not my favorite thing, but it was his daughter's birthday and that's what she wanted, was a roller skating party, and dang if he was going to miss it. He also sings in a band. So you can see him here. There's kind of that tube on his leg. He wears his LVAD equipment in a leg strap so that he can be active in his band. He is in the Duluth area and performs in this band. So LVADs can be put into children. Abbott Northwestern, we treat patients 15 and under. We're attached to Children's Hospital where they treat patients under 15 with devices. But this young kiddo came to us very, very sick. He had a arrhythmia-induced heart failure. So he had a tachyarrhythmia that we unfortunately caught too late. His heart had already failed by the time we figured out that this was a tachy-induced arrhythmia. So he had an LVAD put in when he was 16. He actually came off of ECMO. He was in liver failure. He was in respiratory failure with a tracheostomy. He was in kidney failure on temporary dialysis when we met him on VA ECMO with heart-lung support. We put the LVAD in him. He took about 3 months to recover in the inpatient rehab center. He kind of had to relearn how to sit and walk again and kind of gather all of those muscles back up. He then had an unfortunate complication with his LVAD where he had a clot form inside his pump. And so you'll see the picture with him in his prom dress. Unfortunately, he had a complication right around prom. And so instead of missing prom, his prom date was amazing. She came to the hospital. The nurses decorated a conference room where they had takeout and watched movies and had prom at the hospital. And then about 2 years after his LVAD complication, we actually were able to treat his arrhythmia and see some repair with his heart. And so his heart actually recovered well enough where we've been able to take the pump out. And so this picture of him getting married is 8 years post pump explant. His heart isn't 100% normal yet. He has an EF of about 35%, but is able to carry on full-time work and is moving forward with life. Anything that we can offer this kiddo to kind of progress out. I don't know what the future holds. May he need an LVAD again? Maybe. May he need a transplant in his future? Maybe. But we've so far given him 8 additional years with no device therapy where we're kind of pressing things out for him in the future. So he's just one of my very favorite people to talk with. 8 years is the longest I've had where I've been able to take the pump out and not have to put one back in somebody. My other patient was 5 years before they needed a heart pump in again. It's a very small percentage of patients that we get to take these out on. It's really only about 3 or 4%. But when we do, it's a pretty big success for us and for the patient. Like, look at them out enjoying life. And then we encourage all sorts of fun. Now, water and electricity with their heart pumps don't exactly mix, but I also don't want to take away quality of life from people. So fishing, we just ask people not go out in a canoe or a kayak, right? Go out in something stable. This guy opted to take himself to Canada into the Arctic Circle on a fly-in fishing trip and ran his VAD on a generator for a week. The patient on the beach there, he is 80 years old. He has had his VAD for 1.5 years. And this winter, he and his wife, along with their children, took a massive trip. They went to Hawaii for 10 days and then made a short stop over in Alaska for another week before coming back to Minnesota. So out traveling and living life how we want. And then back to your hobbies, flying airplanes, model car, or old cars, out riding in the woods. These are all the things that we are just thrilled to offer our patients as they were end-stage heart failure patients before they got these pumps put in. If you have any questions, please let me know. If anything comes up, we will be more than available to be here and ready to talk with you if you are at the scene with the patient, or if you need anything else from us, we are here.
Jessica, thank you very much. Do you have any data as far as how many patients that you guys have in South Dakota?
Ooh, I don't. My personal program, we only have a handful. I know the university has a lot more patients, and it's purely because the Stanford insurance plan is in network at the university. So
Okay.
I know that it depends on where you're located. Sioux Falls area tends to be more patients from the university, more in the northern and central area tends to be our patients, but I don't have that specific piece of data. I'm sorry.
Okay, no, that's fine. Thank you. Anybody, any questions? We got one in the room here. Go ahead.
Sure.
Did you hear that question or no?
I didn't hear anything. I'm sorry.
No, that's okay. Do the current VADs, say it again, Gary, sorry. Do the current VADs have much problems with hemolysis?
The new devices do not. So HeartMate 3, we actually at our facility stopped implanting both HeartMate 2 and HeartWare in 2018 when the 1-year data came out with HeartMate 3 because it was so good. So hemolysis and clot formation with HeartMate 2 and the HeartWare pump tends to be about 8 to 11% of patients have the need to have a pump exchange. The HeartMate 3 data, we really see very little hemolysis, and the pump exchange rate for thrombus is actually less than 1%. So they've done a huge improvement with their design of this magnetically levitated pump that they have given us.
Thank you. Another one came in on chat. A patient with an LVAD, would they require a prophylactic antibiotic pre-med prior to any dental treatment due to the nature of mouth bacteria? Yes,
we do. We have everybody do a one-time dose of antibiotics similar to patients with valves pre-dental procedures.
Okay. All right. Well, thank you very much, Jessica. We really appreciate it.
You're welcome. Thank you, guys. I appreciate you.
Thank you. All right, let's take a quick 5 again. Be back as quick as